And welcome to Geriatric Grand Rounds. A few announcements before we get to today's presentation. So our next Grand Rounds, Norma, I don't think that's correct. It says September 17th, but I don't think that's right. I think it must be March 17th would be my guess. And our presenter is Dr. Mara Melton, and the topic is to be determined. So it's a mystery right now. So everyone join in for that to find out what it will be. Our next journal club is the 10th of March, and our presenter will be Dr. Dan Matlock. There is a division meeting after today's presentation, so faculty, please join on to that at 8:30. After today's Grand Rounds, you will receive an email with a link to the recording of today's presentation, as well as a link to an online evaluation. So if you could please take a couple minutes to fill that out, we would really appreciate that. Please submit questions in the chat or the Q&A boxes anytime during the presentation, and we'll hopefully have some time for some Q&A discussion at the end. So we have a different format today. We're really excited to have a panel of speakers this morning. Our lead presenter is Dr. Dan Savin, professor of psychiatry, and also joining Dr. Savin are going to be Dr. Adi in psychiatry, Fardous Ahmed, social worker and case manager, Dr. Aronson and Dr. Chamberlain, both psychiatry residents, and who did I miss? Dr. Vargas. And I think that's everybody. So we were just waiting for Dr. Savin to join us. There he is. Good morning, Dr. Savin.
Good morning.
And so I think we're ready to go. So I'm going to turn it over to you all. And thanks so much for being with us here this morning.
Hi there. Thanks so much for inviting us today to talk with you. Thank you, Dr. Hildreth. I think you're the one who gave us the initial invitation. So today we're going to talk about mental health in the geriatric refugee population. And much of this does apply as well to immigrants. We have a refugee mental health program, but a lot of what we say will apply to immigrants. So I want to say we do have an immigrant refugee mental health program, mostly refugee. It's within CU Medicine, outpatient psychiatry clinic. We have about 135 active clients of all ages. Actually, there's quite few that we would consider geriatric from a geriatric medicine perspective. We do have quite a number in their 60s, a few over 70. You know, we have some kids, a lot of young adults, middle-aged adults. But we think that there's some geriatric issues in some of our 60s to 70-year-old patients that might apply a little earlier in their lives than to some Americans due to some of the difficulties that they've encountered. Some of the services we provide mental health evaluations, psychiatric evaluations. We do some case management, which you'll hear about, medication management, which Dr. Adi is going to talk about, and psychotherapy. Learning objectives, we'll talk about a couple basic statistics, and those will appear in a video that we'll show for 4 minutes. And we hope that this lecture will increase your awareness of some of the psychosocial struggles, particularly to elderly refugee populations. And we hope that through this talk, you can understand ways to make medical and psychosocial interventions more effective for elderly immigrants and refugees. So definitions, briefly, an immigrant is a person who leaves one country to settle permanently in another country. And a refugee is a subset of an immigrant. To receive refugee status, one must prove a well-founded fear of persecution based on race, religion, nationality, or membership in a particular social or political group. When refugees arrive to the United States, their legal status is intact. So we're going to just show about 4 minutes of this video that'll talk a little bit about refugees in the world today. I think it gives a pretty good overview. It's about a year old, but it will not talk about recent events in Afghanistan that have caused, a large refugee crisis, including about 70,000 accepted to the United States. And also it does not include the Ukrainian refugee crisis, which, last I heard, there's a lot of displaced people in Ukraine, maybe 1 million or so. Okay, so go ahead, Mike. Can you just start that?
We do not expect the number of people being displaced to stop. More assistance is needed.
The conflict is raging. Families lose everything because of the shelling, the fighting, the bombing.
I'm truly shocked. We have here a displaced population fleeing after having gone through the most horrifying violence.
COVID-19 has shown us how vulnerable displaced people are to the vagaries of the informal economy.
Venezuelans are trying to rebuild their lives in neighboring countries. They are trying to find a way to provide for their families.
82.4 million people worldwide are forcibly displaced, a devastating tally and the highest on record. Data from UNHCR, the UN Refugee Agency, shows that the numbers have doubled over the last decade. Beyond the numbers lies a human tragedy. Despite a global pandemic, people continued to flee persecution, human rights abuses, and deadly conflicts. 26 million people have crossed borders to find safety. 48 million are displaced within their own countries. Several crises have persisted for years. Some are new, others are emerging.
زي ده ما عرفت عنه لكن اللي بتشوفوا عملوا كان في ماتوا شديد ماتوا والله اي ماتوا قالوا بعد ده قالوا يلا طلعوا مش اي محل كله طلع اي والله.
Tens of thousands have fled from Ethiopia's Tigray region to Sudan since November last year. Millions more are internally displaced and in urgent need of assistance. Nadia, at 17 years old, has been a refugee all her life. Her father fled Afghanistan 40 years ago. In Pakistan, he works 12 hours a day selling rice so Nadia can go to medical school.
He's my life. It's too much important to me. He's too much old, but still he's hard work. He's dreaming that you should be a doctor.
More than 2/3 of all refugees come from just 5 countries: Syria, Venezuela, Afghanistan, South Sudan, and Myanmar. Among the most vulnerable of those forced to flee are children. 42% of the displaced are below the age of 18. A staggering 1 million have been born into a life of exile in less than 3 years. The failure to end conflicts is robbing generations of their hope for the future. Syria's crisis stretched into its 10th year, while Afghanistan, Somalia, and Yemen are still hotspots. In the Sahel, a complex regional crisis forced millions to flee one conflict only to find themselves caught up in another. People are facing multiple threats and struggle to survive extreme weather and changing climate. In drought-hit areas, armed groups exploit tensions over scarce resources. Sayore abandoned his crops to save his family.
Zabrahman terrori ramba attack ramba wanki tondo village ko kuneba sabab kan kitti tondo déplacement waka.
2020 was an unprecedented year. The COVID-19 pandemic tested the world like never before.
So I hope that gives you a little bit idea of what's been going on. The number of refugees in the world today is the highest it's ever been. And really right now it's just going up as we speak. So in the US and Colorado, we'll talk a little bit about numbers. From 1990 to 2017, the numbers went up and down, but averaged about US accepting about 80,000 per year, which is really a small amount compared to the overall number of refugees, but more than a lot of countries, more than a lot of other countries took. So Colorado averaged about 2,000 per year. And then just to show how numbers can be influenced by administration and policy, in 2020, the ceiling for admissions, which is set by the president, was lowered to 18,000, which was far lower than it had been. Actually admitted to the US was 11,800, not quite reaching the ceiling, partially due to COVID, several hundred to US. And then in the Biden administration, the theoretical ceiling of refugees we could accept was increased to 62.5. Actually admitted was only 11,000. That was due to COVID. We have admitted in 2021, 2022, about 70,000 humanitarian parolees from Afghanistan. They're not considered refugees. They won't have permanent status in the United States unless something changes, which it well might. But they're here.
Great. So for this next section, we thought it'd be helpful to talk you through how we think about a case in the refugee clinic. So this is a patient who I'm seeing. He's a 69-year-old Nepali-speaking Bhutanese refugee who has a diagnosis of bipolar 1 as well as multiple myeloma. And he presented for a follow-up appointment. He stayed on his current regimen for a number of years. He has no current mood symptoms. As I said, he's previously been diagnosed with bipolar 1. This diagnosis was made in Bhutan between the ages of 30 and 35. And in Bhutan, he was hospitalized a number of times, but he has not been hospitalized since arriving in the US in 2009. And that's when he started care in our clinic in 2009. He's currently maintained on Abilify and Depakote, and he received citizenship 7 years ago after an N648 from our clinic. And we'll talk a lot more about N648s later in the presentation. So whenever we see a bipolar diagnosis, our first step is to really sort of question that diagnosis. There's a lot of misdiagnosis of this disorder in particular, and it really does change our treatment course. So in the refugee population, this can be particularly difficult. So for this guy, I'll just talk you through my thought process on whether I think he has bipolar 1 or not. So some things that are a little bit questionable in his history that point against the diagnosis are at the age of onset. So he's a little too old to be having his first manic episode between 30 and 35. We usually think that it'll happen in your 20s or a little bit earlier. And some people think there's like a late peak in your 40s, but that one sort of depends on who you ask, but 30 to 35 would be abnormal. And then he's been very stable while in the US, despite perhaps 6 to 9 month hospitalizations, multiple of them in Bhutan. So that would be pretty odd that the severity of the disease changed so drastically. Some things that count towards the diagnosis. So, in the immigration documents, there's reports of these manic episodes that are very convincing, in which he's hospitalized for 6 to 9 months, requiring physical restraints at times during those hospitalizations. And then it's actually pretty hard to be psychiatrically hospitalized in Bhutan. In Bhutan, there's 1.2 psych beds per 100,000 people, which compares to 11.14 here in the US, so about 10 times fewer psych beds, so much harder to be hospitalized. He's on a reasonable medication regimen for bipolar 1. with antipsychotic and a mood stabilizer, but that may just be self-fulfilling, right? We saw the diagnosis, we put them on those. We can't really use that as much data either way. And what this really brings up is sort of how difficult it can be in the refugee population or in immigrant populations to parse out these pieces of information, because in psychiatry, unlike in some other fields in medicine, all we have is the history. We don't have a lab test that confirm this. So all we have is history from the patient's family, these immigration documents. And that's very limited in this case. The language and cultural barriers limit it. The family's main symptom they report when this patient is manic is dizziness. And that's despite a lot of psychoed and describing, a bipolar picture to them. But dizziness is how they sort of get at mania. And then, like I said, in general, the history is opaque, and that's pretty challenging in our field. During my time in clinic, I was actually able to see him sort of ramping up into a manic episode, so sort of confirming the bipolar picture. And what happened is in July, we transitioned from the previous third-year psychiatry residents to our third-year psychiatry residents. And those transitions can be really hard. And so this guy was a little bit lost to follow-up, was running out of medications. His son called and was able to get a refill and an appointment the following Friday. This speaks to the difficulty of transitions, the overall benefit of social support in these folks, which we're going to talk a little bit more later. And being restarted on his meds, he was able to abrupt what sounded like a ramping up manic episode. For 5 to 6 days, he had been out of his meds. And then for 4 to 5 days, he was only sleeping an hour and a half a night. His thoughts were racing. He had an increased rate of speech. With the restart of these medications, these symptoms had all gone away. So let's talk a little bit about some of the data we have around this population. So this is a graph from a study done in Canada. And the goal of the study was to look at mental health outcomes, comparing immigrants and Canadian-born respondents. And their main goal was to explore the healthy immigrant effect, which is this idea of physical health, that recent immigrants tend to have better health outcomes than folks who are native-born. They examined 12,500 immigrants, of which about 1,500 refugees, and compared that to 180,000 Canadian-born respondents. This was done through an annual government survey. I'd say the main limitation of this study is the primary outcome was self-reported mental health. So they asked folks on a Likert scale of 1 to 5 to rate their overall mental health. So obviously just a self-report there. But some things to highlight from the study. So if you'll notice, the refugee folks have much lower self-reported mental health than the Canadian-born respondents, which is represented by the red line. So refugees are reporting doing worse in that sense. They did find the healthy immigrant effect with mental health held as well. So recent immigrants did well in mental health outcomes. These stars represent statistical significance. And as immigrants became more established, those gains tended to fall off, which is what they saw in physical health measures too. Some other things to note from this: folks from the Middle East and folks from East Asia tended to do a lot worse than other groups and Canadian-born respondents. And that's particularly salient for our group because these are most of the folks we see. Most of the folks in our clinic are refugees from the Middle East. The East Asian folks, that would include the patient I just presented from Bhutan. So this is the same study, and obviously a little bit of a grosser graph, but I'm going to focus on just a couple pieces here. So if you look, so this is that same outcome, the refugees reporting lower mental health. The odds ratio less than 1 means worse reported mental health. But they did this logistic regression, and they controlled for different variables. And what they noticed, so adjusting for age and sex, it's still significantly worse. But then when you start to adjust for other things, so when you adjust for social factors like language proficiency, education, and marital status, that significance disappears. And then furthermore, when you adjust for economic factors, so they adjusted for income decile and employment status, not significantly so, but the refugees actually had higher self-reported mental health outcomes than their Canadian born correspondents. And so what that suggests, I think, is something we all sort of knew and think about, and that's that some of the best things we can do for our refugee patients is help them with these social factors, which is something our social worker Fairuz is going to talk more about later. But things like language proficiency, education, employment status, or citizenship, these are things that have huge impacts on how well our refugees do. I will not go through all of this for the sake of time, but two other things to note is even when controlling for these factors, immigrants from the Middle East and from East Asia still do a bit worse than folks from other places or folks who are born in Canada. I won't go through all this right now. Okay. This next study comes from Albuquerque, and they were looking at refugees from Afghanistan, Iraq, and the Great Lakes region of Africa. And they did both qualitative and quantitative data with these folks. And the big thing to note on this is just the effect of family separation. So these are just basically a bunch of ways of quantifying severity of mental health symptoms. And in every case, in this case, refugees who had been separated from their families did worse than those who had not been separated from their families. One thing they didn't control for that I would like to see is overall trauma exposure. So you also notice that folks who were separated from their family had a lot more trauma exposure than those who weren't. And so that may be confounding all the other things in this study as well. One thing that was neat about this study is they did pretty long interviews with each of the participants and got some quotes that I think really help demonstrate some of the problems that our refugees face. So in this quote, "I'm not okay physiologically. I feel really bad all the time, depressed because we left our family in Iraq. We always hear of explosions and bombings in Iraq where my family lives in Baghdad. It's not a very safe place. I'm not really happy." So I think this speaks to the fear that these folks often have about the family they left behind and their safety. This next quote: "Since my daughters are over there in Iraq, I cannot help them. I cannot sit with them, see them. So if they just gut here, I can help them with their kids, like watching their kids, maybe feel comfortable when I see them. Iraqis want to talk and to see each other. So I feel good if I do that." So sort of this idea, I wish I could be doing the normal things that I could if I were near them. I could be helping them with their kids. I could be helping in all these other ways. And then finally, actually, I try to not contact them very much because I do not want to tell them the issue, the truth. Because our people, they know America is a very great place and all the people here are very happy and rich, but this is not the truth. Then I cannot call them and tell them that these things have not happened to me. I cannot tell them now what's happening right now. That's difficult. So this idea that for many of these folks, America was an escape from a lot of the bad things that were happening, back home. And if they're still struggling in the United States, they don't want to tell their family, who in many cases sacrificed a lot to get them here. They don't want to tell their family back home that they're still struggling or that they're having mental health problems or problems getting a job. So they're really torn there.
Alrighty, thanks everybody. I wanted to change the topic a little bit and talk about another case that kind of illustrates another important issue that we often deal with in our clinic. So this is talking about a 67-year-old woman from Iraq. She was a teacher and then a principal of a school in Iraq, and she actually fled her home country in 1994 to escape violence. At the time, she lived in Jordan for 20 years before eventually being able to come to the US. She was joined in that journey by her 2 adult sons and 1 daughter. Unfortunately, her husband was killed in Iraq while trying to cross the border. So she came to our clinic and initially complained and had a positive ROS for low mood, nightmares, intrusive memories, all kind of related to some of these traumas that she witnessed during the war in Iraq. Poor concentration, memory, decreased appetite, insomnia, avoidance behaviors, hypervigilance. So we diagnosed her with PTSD. And interestingly enough, she cycled through a few different medication treatments for PTSD pretty quickly: sertraline, then duloxetine, Lexapro, prazosin. Very sensitive to side effects and often would stop medications kind of on her own, complaining of nausea and headaches. But the medication seemed to be kind of second to what her primary reason for coming to the clinic, which is that she requested a letter to bypass the citizenship exam. And this is a request we get quite a bit. So if we go to the next slide, I'll talk a little bit about US citizenship and why it matters for folks. So a lot of the refugee patients that we see are pursuing, U.S. citizenship. There's a few reasons why. One of the main ones is certain benefits. Social Security benefits, especially, expire after 7 years in the U.S. if you don't obtain your citizenship. And for a lot of our patients that we see, that's sometimes their primary source of income. They really need these benefits to survive here in the U.S. So that's a big deal for them. There's also travel limitations if folks don't have their citizenship and are just on residential status here in the U.S. And so that's a big deal for a lot of folks. And then there's this more kind of intangible sense of identity or sense of belonging, and also a sense of safety that comes with obtaining U.S. citizenship. A lot of our folks, they've all fled their home countries for various reasons, and they're looking for a place to belong. And they've seen pretty traumatic things in a lot of cases, and having a kind of a home base and feeling that sense of security that comes with citizenship, and not being able to say that they're a U.S. citizen is really important for a lot of people. And so some of the base requirements for citizenship: you have to have at least 5 years in the U.S. And so a lot of folks come to us at that kind of 5-year mark, asking questions about citizenship and how they can obtain it. You also have to have this more vague thing that USCIS requires, which is good moral character, which is kind of as vague as it sounds and can encompass a lot of different factors. I'll talk a little more about that with this case here at the end. And then you have to pass an examination. So you have to prove that you can read, write, and speak basic English. And you have to demonstrate a knowledge and understanding of U.S. history and government. That's the civics portion of the exam. So there's a lot of barriers to citizenship. Age, education, disability are all kind of factors that play into whether somebody can obtain citizenship. There's a few common diagnoses that we often see that affect a person's ability to learn, and specifically an ability to pass this examination. The common ones that we tend to see are PTSD, major depression, neurocognitive disorders, traumatic brain injuries, schizophrenia, bipolar, and then learning disabilities and intellectual disabilities also kind of come into play. So often when we see a patient who has one of these diagnoses or has something that's a disability that's preventing them from learning English and passing this exam, what we can do is use one of these N648 forms. And it's basically a medical certificate for disability exemption from taking the examination portion of the citizenship test. When considering somebody for one of these forms, what we'll often do is kind of dig into the specifics of how exactly their symptoms or their disabilities prevented them from learning English. We'll get into details like how many English classes they've taken over the years, how many attempts at learning English, whether they've had a private tutor or gone to a group class. Those are all kind of important things. And then how specifically has their disability prevented them from learning. We also consider kind of broader things like daily functioning. Do they have help with ADLs? Do their family members help them with driving? Do they drive on their own? Things like that also kind of come into play. And then we'll often do kind of a brief cognitive screening, use a brief cognitive screening tool as well. It kind of gives us a little more information, helps us write these forms. So for the next slide, so this patient that I was talking about, the 67-year-old woman from Iraq, we wrote in N648 for her. It was clear that her symptoms of PTSD had affected her memory and her concentration and her ability to learn English. And the N648 form was accepted, which was great. But unfortunately, her citizenship application as a whole was rejected. And this was for that more vague reason I gave before, these concerns for moral character. And in this case, the concerns that USCIS had was that the patient had left the US for 6 months to visit family in Iraq. And at that time, she continued to receive SSI payments. And the USCIS officers were concerned that this spoke ill of her moral character, that she abandoned her residence and still received these payments. She was offered opportunities to kind of prove that she hadn't abandoned her residence here in the US, or that she hadn't received these payments, and she was unfortunately unable to do so. And in these more complicated cases where there's these other factors at play, what we'll often do is recommend an attorney, that patients find an attorney that can kind of support them through this, because it does get very kind of complicated very quickly. She was unable to find an attorney or unable to pay for one financially. And unfortunately, when we have these cases where citizenship applications get rejected, it can exacerbate kind of mood symptoms that patients had, especially with this patient. Her PTSD symptoms seem to be exacerbated after the citizenship rejection. The good news is it doesn't mean it's kind of the end of the line for her. She can reapply again. She doesn't lose her residential status. And so, we'll continue to encourage her to do so, to reapply again, and to find a lawyer to help her kind of sort through some of these moral character questions that the USCIS had.
Thanks, Dr. Anderson. Hi, all. And as you can heard about Dr. Anderson, base touched about all the complicated resources that's so important to the patient's wellness and health and wellness. I want to also talk about it a little bit more in a culturally responsive way. How do we mostly effectively, support and provide resources and connections to the elder refugee? And I want to begin with the basic needs services that should be provided in a safe and culturally appropriate manner that promotes equality and dignified access for the elder refugee. We all know that there is a lack of affordable housing and poor condition housing in Colorado and all. But there is not only that's not the case only. The lack of cultural consideration is also another issue that we all consider when we serving for the elders. So, for example, inconvenient housing. And as we know that because of the low income housing and public housing, it takes so long to get them. And when you get that, actually, they don't have a choice to choose where they're gonna be located. So they have to provide it from the housing authority and locate them, far away from the community, far away from central places and shopping malls and groceries and, places that they could connect to from their own communities and such as, mosques and churches. So it's very complicated. So promoting and helping connecting convenient housing and resources is always helpful. And it helps the seniors to keep active and socially connected to their community. I also want to talk about the term elderly, and understanding the definition of elder differs from culture to culture. And this is very key to understand when you're serving for elder refugees. Individuals who are aged 55 or elder perceived some cultures and communities, as an elder. Don't worry about it. If you're 55, you're good here. If you're in the United States, I'm just talking about the separate communities. And yet, they do not eligible for many services or public services that they could be able to eligible because of that age differences until they reach 65 or above. And also there is an incorrect date of birth. So as we all know, because of many refugees fled from war, did not have the access to a birth certificate, right? So some may not even know when they were born. So, people just create agencies that work under resettlement agencies overseas, just, make a date, right? So I did work with a lot of clients who are 70, but then the paper says that 62, and who are, 55 or 60, but they are aged as 70. So because of that incorrect date of birth, and because of the culturally not understanding how they really define the term of elderly, also really affected how they would get benefits. And they definitely denied a lot because of that age gap. And I wanted to, when we're talking about culturally responsive way, how do we really understand that and how do we help the elderly? I also want to talk about information and education. It's really very important, providing outreach and information through sections and one-on-one or group meetings on a different topics, such as access and available resources. So they need to understand because of that, age gaps or the definition of culturally understanding your age, what resources available for you, where to go to correct your age if possible, or what can you get from that. Also teaching elder abuse, right, and resources available for them. Family violence, legal issues, finance, healthcare, and also teaching them how to navigate the government system. So if you're not eligible, right, this kind of services, where to go or what can you do, such as citizenship, study or citizenship benefits. I think Dr. Axon talked about it a lot, the challenges. In you elder refugee who are 70 and never go to the school and don't understand culture and English, is very hard for them to learn English, the language, or the civic or the US, history, right? And then if they can't be able to do that, do you know the right resources to connect to them, such as our clinic, right? How could we evaluate and assess and help them that report? So it helps. Providing education and outreach also helps. Let me see. If you can get the next slide. Thank you. Also focusing, offering activities such as classes and cultural activities, dancing, cooking, and what does it work for them really? And when talking about activities, not just asking them to go to the exercise and do this, but what do they like to do in activities? I took this picture in 2018, and if you can see that picture, it was around 12 different countries that came together elderly and playing their own game. So that board, those guys who are playing the board are Somali guys, they play what they call shah, and that's really a board game, which they really love it. So they don't just play it, but it promotes socially connected and they solved a lot of issue in a back home, such as a clan and family issues and supporting each other. So it's a big deal. So understanding culturally activities and what can make them really do what they want to do, it also helps. Emotional support, it's another thing that we need to consider when we really helping the elders. So group therapy or counseling or family support. And I think both Dr. Anderson and Dr. Chamberlain talked about, the worries about a family back home. So how do you connect resources for family reunification or support that they can really get? And also if you can facilitate opportunities to promote a civic engagement participation, and also volunteering within community through social events and other social, special projects that the elder would love to participate would also help. I also want to talk about, lastly, self-achievement and dignity. Elder refugees, and this depend in a different culture and country, but back home, they are very important. They have a very good role, right, within the society. As you aged, that's how people really respect you on the table. Ask you, seek, people seek advice from you. Elder try to solve all the issues within the society. But when they come here in the United States, they kind of feel like they are nothing, just sitting at home, watching everybody doing what they want to do. And for them just to wait and receive, very little, resources. So providing support and enhance their local, emotional and physical and intellectual and spiritual and lives to promote active participation in all aspects of community life to help reduce the risk of social isolation is very important, and facilitate opportunities for elder to their voice interests and influence the policy. If they could be able to do some employment programs or housing or, whatever they like to do in terms of sitting. So I think all of this, because of they don't have the connections they used to have back home and the respect, we as a culturally, in my culture, we really respect the elders so much. And here in the United States, even though there's always respect around, but people think you elder, you need to, get rest and sit and just do wellness activity. You don't have to do anything. But back home, they want to really to do so much within the society. Thank you.
All right, well, thank you so much, Fardous. You might need to mute yourself because I'm hearing some echoes there. But all right, well, thanks everyone. So I thought I'd kind of come in here at the end and give you some medical kind of tips and tricks that kind of sum up what we are talking about here. And some of those might be relevant for all of you. Some of those might be relevant for people who are just only medication prescribing providers here. So the first thing I want to talk about is that always keep in mind that symptoms are often reported very differently in refugee populations compared to non-refugee populations, especially psychiatric symptoms. So as you've seen with Dr. Chamberlain's case, like the individual with bipolar 1 always reported his symptoms as quote unquote dizziness. In my own clinic, since I'm Arabic speaking, most of my patients are Arabic speaking, and I almost never hear I am depressed or I am anxious. I always hear I am tired. And I kind of have to like try and parse out what exactly is I am tired with them. So keep that in mind. If you're getting a lot of somatic complaints that seem kind of vague or don't have very specific kind of medical underpinnings, they might be a representative of a psychiatric process. The second thing to bring up is that elderly refugees often don't know what medications they are on. So self-report is not reliable. So it is very commonly the case when I would ask a patient, what medications are you on? And they would be like, oh, I don't know, I take 20 pills. And they can't really tell you what any of those are. So one tip and one way to kind of like go around that is ask them to bring all their medications to the appointment so that you can actually look at the bottles yourself. If you're seeing them through video conferencing, like or a virtual evaluation, you can ask them to kind of bring the bottle close to the camera and then you can read that. If it's on a phone evaluation, that's definitely a little harder. So if they can read up or spell out the name of the medication to you, you can ask them to spell it out letter by letter and see if you can get any information that way. Or you can ask if there's a family member close to them who can read the names of the medications for you. And that's one way to try and figure out or verify what medication someone is on. Related to that issue with medications is also issues with compliance and pill burdens. So with compliance, it is pretty commonly the case that also like refugee patients, generally speaking, but also elderly refugee patients may just stop all their medications without telling you because of some perceived problem or side effect, or just thinking, hey, I'm taking too many pills and I'm just gonna try and cut it short and just stop taking half of them and see what happens. So as you have seen with Dr. Aronson's case, that Iraqi lady has stopped taking all her medications at some point. This is a relatively common occurrence in my clinic, and I have to do a lot of education about the importance of taking your medications regularly every day. And then the topic of pill burden comes up, which is like a lot of times refugees coming from other cultures perceive taking pills as a sign of weakness and a sign of illness, that I am not well if I take 5 tablets instead of 4 tablets. One of my patients from Syria like kind of stood out to me because he was suffering with like pretty bad anxiety, depression, PTSD, but was very, very resistant to me starting him on any medications because he felt like he was taking too many tablets or pills, and would tell me things like, well, when I was in Syria and I had a cardiac problem, they only gave me 2 pills, but then I came here and I had a cardiac problem and they gave me 6 pills. So there's a lot of education that needs to happen that the number of pills you take does not correspond with like your well-being or your innate sense of being the sick person. If there are any, so some tips with that is that if there are any medications that are combo medicines or any meds that you can realistically actually stop, do that. Your patients will appreciate you. And then with regards to the compliance issues, consider helping your patient get a home health aide or a home health nurse and do some liaising with that home health aide. So I do that with some of my patients, and I actually just call their home health aide after the appointment and ask them what medicines are they on and tell them what the changes are going to be. Or enlist the assistance of their family members if they have family members who can help them kind of work on their pill box or kind of make sure that they're taking their medications every day. Next slide. The last couple of things, also some practical stuff. So do not assume that your elderly refugees can call and make appointments for themselves. Part of that might be language barriers. So even when you tell them you can call the clinic and ask for an interpreter, the mere process of calling someone who does not speak your language and you stumbling through the words and trying to tell them that you need an interpreter is anxiety provoking, and like kind of for the elderly refugees that they avoid it altogether. So for some of my patients, I give them like a direct number, like a direct line to my voicemail, and they can call and leave voicemails in Arabic. And then I can kind of respond back to them or ask someone from the clinic to respond back to them. Another thing that comes up in this population is that I have a good chunk of patients who are illiterate. So you might meet patients, especially elderly patients who have not been through any formal education, may not be able to say, write something down or remember when the appointment's going to be because they can't write anything down. So that's another piece where you have to do some problem solving, either with a home healthcare nurse, either with like a daycare program that they go to with a family member, for someone to be able to like get the information that you need them to know. For example, when's their next appointment? Lastly, I want to throw that out there just for our any colleagues or providers that do prescribe medications for patients, especially with elderly populations, and you guys already know this, but try your best to avoid benzos and anticholinergic medications. because those can have a significant effect on cognition. And when you have a patient who already does not know how to describe their symptoms to you, you're going to have even a more compounded picture of someone who cannot really tell you why what they're taking is affecting them and how they're being affected. One example I can bring up from my own clinic in this is that I had a patient refugee from Syria who had a primary care doctor who was not at the university, and then I was her psychiatrist here. And in one of her appointments, she told me, "Doctor, I started taking this new pill and my head is big." And we kind of had to sit together and try and do some kind of clever investigation into like, what exactly is my head is big? And eventually through the controlled substance database, I found out that her primary care doctor tried to give her a short supply of Restoril, temazepam, to help with sleep, and that did not go very well for her. So just keep that in mind, that like some medications that are not very good for elderly populations, generally speaking, specifically in refugee patients, they might not be able to tell you what they're taking and how they're being affected by it. So, all right, well, next slide. Thank you all, everyone. This was kind of my way of wrapping up the presentation with some practical tips and tricks. For the sake of time, we will stop for now, and we're happy to take any questions. I saw that there were some Q&As that came up through the presentation, and I think maybe Dr. Chamberlain was able to answer some of them, but we're happy to take any questions.
Thank you so much. That was wonderful. I'll turn it over. It looks like there are some questions coming in. So if you guys want to figure out who wants to address those, that would be great.
So I'll read the one from Samantha Farrow. Can you speak to how you work with immigrant refugee patients to increase a sense of safety and motivation for treatment? For example, a patient who is clearly being impacted by significant trauma or grief, but is so overwhelmed with so many basic social factors, basic needs, that the thought of treatment is off the table for them. Well, I'll give a brief answer to this. When you ask motivation for treatment, I think we have to ask, what is treatment? And I think in our clinic and probably in yours as well, treatment in this case would begin with helping with the social factors and basic needs. And that is generally how our patients, especially the ones who are severely impaired, gain trust in the treatment team, is through us helping with social factors and basic needs. That itself can improve symptoms, and it also can increase the likelihood of a patient accepting a referral from a trusted physician or provider for mental health treatment. So I think first is establishing trust yourself and doing what you can to help with other with basic needs and social factors. Does that answer the question? And I think also people do have some stigma. A lot of times there's stigma of mental illness, and you can talk with them and kind of just say, well, this is another doctor or a healthcare professional that wants to help you with. And you can say whatever the patient says, like Dr. Adi said, well, the patient says, I'm tired, doesn't say I'm depressed. Well, you can say to the patient, well, to help you with being tired, to help whatever the patient says their problem is, that is what, you don't have to translate their problem, whatever they say their problem, tired, into our word, depression. If you think it's depression, depression doesn't translate real well a lot of times into other languages, because the way medical people in the United States think about depression, they think of a list of 9 symptoms a lot of times. A lot of times it doesn't even translate into English. But to translate it to another language does not often work real well. So take what the patient says tiredness or big head, if you think, or fear, not being able to sleep or being woken up at night, there's specialists that help with that. You don't have to call it a diagnosis, or because people, especially people from, a lot of very countries that are developing countries, when they think of mental illness, they may think of perhaps the one major psychiatric hospital in the country where the schizophrenics and severely disturbed people are, and perhaps maintained in terrible conditions. They think about that. They think, no, I don't want to go. So, okay, that's my answer.
I just wanted to add, there's a question about psychotherapy and CBT. I think just to add to Dr. Savin's point, many of the folks that I see in psychotherapy are not used to the space of psychotherapy. So part of the process also is to help people familiarize themselves with what the space of psychotherapy is for. And of course, CBT and other specific interventions can be helpful, but a big part of it is just to help people understand what we can do in a psychotherapy space, in addition to the treatment with medications and interventions that were mentioned in the presentation.
I just want to answer real quickly. Thanks, Laura. I just figured out how to look at these questions. So health insurance provided to refugees, the answer is Medicaid. Afghan arrivals will also have Medicaid. Cognitive screeners. I think the best one is the RUDAS, RUDAS. I think that's pretty culturally can be used across many different cultures. We also use the MOCA sometimes, which is translated into multiple different languages. But I think I like the RUDAS the best. Okay, that's all for me.
Great. Well, we're at 8:30, so thank you all so much for this presentation. This was really, really wonderful. You guys all added so much. So thank you so much for joining us this morning. Just one more quick addition to the announcements for everybody. The next Grand Rounds is March 17th. Dr. Melton will be presenting, and the topic is hypersexuality in dementia and sexual consent. So please join us for that. Again, thank you everybody for participating, especially all of our panelists. We're really grateful for your time. Thank you, everyone.
Thank you.